EM board bombs.
Welcome back to EM Board Bombs. What's up, Briggs?
Hello. Sorry, I was sipping my iced coffee.
I know, right? I'm Multafat. I've got my counterpart, Briggs, here. We don't really do much more introduction than this because if you don't know by now, you should know after hundreds of episodes.
Yes.
Emergency medicine, board stuff, life stuff.
Yes.
And let's move on. A 34-year-old male is brought to your ER after a Fast and Furious leveled MVC. Apparently he had a old Supra that he had tweaked out and the axle broke because of how big the engine was. He's hypotensive, tachycardic, and his shirt looks like a deleted scene from The Red Wedding. The fast is positive. You activate MTP like the trauma boss that you are. And then after 6 units of packed red blood cells, he's still hypotensive.
Oh, no.
Yeah, so clearly this guy needs a little more than Dominique Toretto's family to pull through. There were about 5 pop culture references in that. Hey, what's the next best step? Is it A, administer 2 more units of packed red blood cells? Is it B, start norepinephrine infusion? C, transfuse FFP and platelets? Or D, give IV furosemide to prevent volume overload? Hey, the easiest way I know I'm aging myself out is when I give Fast and Furious references, which is why I put that in the stem here with my residents. And they're like, yeah, I don't think I was born or, I could not drive.
Yeah.
But hey, I mean, the first one came out. Hey, Briggs, EM Rapid Bombs, got to promote that.
Right.
You can, search for us on Spotify, EM Rapid Bombs. You can sign up through Spotify or you can just go to our website, emboardbombs.com. Or if you're on our Spotify app, search for EM Rapid Bombs, sign up. It's got hundreds of podcast episodes related to board review, 2 to 5 minute long episodes. Knock everything out. It's great for just general EM life as well.
Right.
Hey, Briggs, what's the correct answer here?
Correct answer is going to be choice C, transfuse FFP and platelets to maintain that 1-to-1-to-1 ratio. So, hey, we're talking about mass transfusion protocol here, MTP. It's really funny. MTP is such an amorphous thing. I feel like even if you ask any of your attendings, if you're a resident, or you ask your hospitals, whatever resuscitation department or whatever guidelines, blood bank, you're like, how do you define MTP? And they're like, well, it's really just a state of being. It just depends on the situation. In every hospital you're at, even up to date, even all these, trauma guidelines are like, well, it just depends.
The cooler, whatever fits in the cooler.
It's just the cooler, the whole cart of blood, whatever. Anyway, so...
Hey, so what is it?
What is it in reality? So the big thing, it's really defined formally as greater than or equal to 10 units of PRBCs in 24 hours. The problem is, though, is that you're not living in 24 hours. You're living in the here and now. So you can't ever think in your head, because I've done this, and it's like, am I going to use greater than 10 PRBCs in 24 hours? Well, I don't know. It's just hour 1 right now. So hour 0. More practically, it's greater than or equal to 4 units in 1 hour. How about that? That's a lot easier with ongoing hemorrhage. Or you're just, hey, we don't even have to wait for 4 units. You're giving 1 and you're like, this is going to be bad. You just know that you're going to need more than 1. And so the idea is that you're going to activate MTP.
It is bad.
Yeah. Every level 1 trauma center has an MTP protocol.
Oh, yeah.
I should say MT protocol. How about that? MT.
Hey, don't get hung up on the numbers. Don't get hung up on the numbers.
Yeah, exactly. Don't get hung up on the numbers. But every trauma hospital has this. Level 2 trauma centers have this too. Right. And so if you're working at more critical access hospitals, hey, you're probably listening to this and you're like, hey, I'm happy if we have 4 units total.
Right.
For 24 hours.
Right off the bat.
We hear you. Yeah. We hear you. We're very privileged here talking about this. Yeah. But don't get hung up on these exact numbers, as Dr. Hussein has said. The key is the patient's bleeding to death. You need to resuscitate them. You're concerned that automatically you're going to go past probably 2 units immediately of PRBCs, potentially, if that's what you use. And that's when you activate MTP. Now, there are a lot of validated clinical scores here, clinical triggers, but here are the red flags. So I know trauma gets the most attention here. So, of course, the classic shock perspective. The most classic perspective here is the systolic blood pressure less than 90, heart rate greater than 120, with an obvious
Tachycardia is so
blunt
key.
or penetrating injury. Yeah,
Tachycardia is so
young
key,
people
right?
especially with that tachycardia. Any obvious penetrating truncal injury with hypotension, positive fast with hypotension, ongoing GI bleed. So getting into the medical, causes here of hemorrhage,
Right.
ongoing GI bleed, and they're hypotensive or altered. Massive,
But the hemoglobin
postpartum.
is like 12.
Yeah, exactly.
Why are you giving?
I love that. I love it. Actually, less and less
Anyways.
people are falling for that now. It's been great.
I know.
A lot of
Yeah, it's
education
great.
on that. Residents, I don't trip them up on that anymore. They know. They're prepared.
They know.
They know. They've listened to the podcast. Massive postpartum hemorrhage, again, another medical cause.
Hey, EM Rapid Bombs. We're doing a
Yeah,
short
rapid
series
bombs.
on
There
this
we
right
go.
now.
I know we
Sign
are.
up.
There we go. So if your gut says, hey, we're going to need a lot of blood, it's kind of like that scene from Jaws. We're going to need a bigger boat.
Yeah. Yeah.
It's
yeah.
all these movie
I
references.
recently rewatched that, by the way. And it was
I
like,
did too.
we're going to need a bigger boat.
It's-
Anyways. Yeah.
Yeah, exactly. Anyway, hey, what are the initial labs you're going to send? Well, these are automatic. Again, you're in the resuscitation bay and you're part of a trauma. Most of these are protocolized, which is great. You don't have to think about this. Type and cross match, got it. If you need more blood, you're going to need that. You're going to run out of emergency release quickly in your little cooler. And then, of course, all the typical blood things, CBCP, PT, PD, whatever, INR, all that stuff, Fibrin. We're not going to focus on that.
Fibrinogen.
Hey, but ionized calcium is really important. We're going to talk about that in a second. Keep that in the back of your brain. So important as part of resuscitation. Hey, but what is the classic ratio here? Why don't you get into that? The classic MTP delivery method, because this is the part I think a lot of learners get hung up on. Is what are the order? What are we doing here?
Yeah. So 1 to 1 to 1.
Mhm.
Packed red blood cells, FFP, platelets. So those three things, 1 to 1 to 1. This is going to mimic whole blood, and it's going to help reduce some of those coagulopathies, right? And that's why you're getting some of those labs, those specific labs that we mentioned, right?
This is
don't forget
critical,
some of the
though.
other things.
Yeah, this
right?
is so critical.
Yeah, so some of the other things are TXA. You can give that early in trauma. We're not going to get into whole TXA debates and all this other stuff, but TXA is one of them. I can give it early. It's 1 gram over 10 minutes, then 1 gram over 8 hours. Calcium, for every 3 to 4 units of packed red blood cells, give 1 gram of calcium gluconate, or you can do chloride if you've got central access.
Why is that?
And you mean central versus?
No, the
glucose?
calcium. Why? Because this has been receiving more and more attention.
I
And
get
our
it,
center,
yeah.
thankfully, we pay attention to this. But I remember a few years ago, this was very vogue to suggest even doing this in the resuscitation bay. At least when I suggested it, it was vogue. But
Oh, stop it! All right, just tell them why. My
so
God, I
citrate
swear.
will bind calcium.
I knew
Citrate
you're so
in blood
excited
products.
to talk
Oh yeah,
about
that's
this.
what it
You're
is.
so, just go. Right,
And
talk about
when the
like
citrate-
precipitates and things. All
Yeah,
right, go.
precipitate that. Citrate binds calcium, and that will cause hypocalcemia, which leads to downstream problems, more hypotension, potentially arrhythmias. And this was only probably within the past 5 years it got a lot more mainstream attention. I mean, it's been around, talked about for a while, especially on the military side.
Yeah,
but-
I'm proud of you for just stopping there. Thanks, and not getting into the further things. I know you're itching to get into some chemistry, but I'm going to stop.
No, I would never
you.
do such a thing.
So I'm going to hold you back.
No, I didn't. I never liked chemistry in college either.
All right.
So
And then also fibrinogen. So consider it when.
yeah, when the levels are low. I mean, this is part of your. A lot of hospitals are doing TEGs now. We're not going to get into that, but when your fibrinogen level is less than 150 or something, you're going to do cryo. That's the only reason cryo precipitate would enter the conversation here, but that's really not going to be a board question.
Big one there is really calcium.
For sure. And TXA.
So-
But that's more in the field.
Yes, exactly. Less than 3 hours. Yeah.
So one interesting thing that I heard is whole blood. Why don't you talk more about that? Does your hospital do that?
So whole blood.
Yeah, we
Yes,
do too.
we've got it. Yeah, exactly. We've got it kind of ready on hand.
Yeah.
So many centers are now using low titer O whole blood in traumas, especially pre-hospital. Some of the benefits, obviously, is better volume expansion as opposed to giving. I heard a resident recently say NS instead of normal saline. I thought that was, I've never said NS before. Anyways, better than that. And then fewer additives as well, and then less dilutional coagulopathy, right? So if your shop's got it, use it.
It's non-GMO, organic.
I know, right?
Yeah, big push.
Farm
Yeah.
raised.
Farm raised. Grass fed.
Farm raised. Farm to table, farm to OR. So if your shop has it,
Donor to table.
use it. Yeah, exactly right.
Donor
Then,
to door.
Oh man, we've got to move on. So it's the 1 to 1 to 1 is still standard if you don't have whole
course,
blood.
yeah. That's
right?
so important.
Obviously,
Yeah.
you're not giving like volume, LR and normal saline stuff. You're trying to do this. So you do not need to switch to FFP and platelets until whole blood is no longer available.
Yes.
Right.
So important.
Yeah. So, hey, whole blood, you're giving it, how much of that? Sometimes
really depends on your availability.
Yeah.
But typically most hospitals, at least ours on average, is like 2 to 4 units are spared, and then you're switching it over to the individualized products.
Yeah.
So it does depend on inventory and availability and whatever your protocol at your hospital is. So don't ever try to memorize that. But just know that this is something that's becoming increasingly common, especially in the United States. I was listening to another podcast recently about how this is really a pioneered effort in the U.S. of doing whole blood compared to a lot of other countries. So
yeah, like EMS carrying it as well. It's kind of like a really big
crews,
thing.
Yeah.
Yep.
Yeah. Exactly. So if you do exhaust your whole supply of whole blood, that's a whole different problem. Then you can switch to 1-to-1-to-1 ratios, and that's what you're doing after that. So, complications are big here. So we already mentioned one downstream complication, which is that hypocalcemia, which is due to that citrate binding calcium. Some other issues that I don't see really. Have you ever seen hyperkalemia from old PRBCs? I've never seen that, and I know someone's going to write us now and say, "Are you kidding me? This is
so if common. I see that complication, I'm like, usually that's a good thing because that means that we saved the patient."
Exactly right. That seems very downstream. So again, that's maybe my bias of being in the emergency department. Hypothermia, big thing, right? And so that's why a lot of modern blood warmers are with that administrator instead of just pressure bagging. You should always pressure bag, right? As well while your team is setting up the either if you have a Belmont or level 1 infused or whatever you have at your hospital, don't just like troubleshoot the rapid infuser. You should be hanging a bag in the meantime, pressure bag. Sure. Don't ever waste time. And then of course that dilutional coagulopathy, which comes from not balancing your ratios. If you gave straight PRBCs, like 20 in a row or something, and you haven't ever thought about giving something else. And then of course just that downstream acidosis from shock, right? And just cold blood makes it a lot worse. So always warm blood up. Always warm the patient up too. Always cover them. Get warm blankets much as possible. And that's that. It used to be called the triad of death. Now it's the diamond of death because they added in.
Really?
Well, guess what they added in?
What?
Hypocalcemia.
Get that guy.
I'm not making this up.
Are you making?
No. Why would I ever make this up? Why would I ever make this up?
No, you're making that up.
No, I never would. I would never do such a thing. Hypothermia, acidosis, coagulopathy, hypocalcemia.
Oh my god!
The silent killer.
Ridiculous. This is so.
So when you
know
stop
what's going to
MTP,
happen after this podcast? There are going to be so many like residents and attendings like dropping hypocalcemia in there. They're going to be like,
that's good.
The diamond.
We're raising awareness.
The diamond. Okay, fine.
We're raising awareness. This is what the podcast does. When are you going to stop MTP?
It's basically once the bleeding's controlled.
I thought you were going to say when the patient's out of the department.
Yeah. And
when the patient goes to the OR.
Take the cooler with you. Take the cooler with you. It's like I feel like it's like that football the president carries, with the nuclear
the codes.
That's like where the trauma thing. Probably a bad time to mention that, by the way. But anyways, it's like the trauma or MTP. That whole cooler feels like that. It feels like it's like strapped to somebody.
Yes, exactly.
And there's like a special code that you're like going through to like open the cooler and then to close the cooler.
Yes. Hilarious.
Hey, let's, for the shorts, let's summarize this all up.
Yes.
And because we're done with the episode for all intents and purposes. So for the TikToks and the YouTubes and all that stuff that I still don't know that Marlena and Alexandria have to correct me on. Briggs, let's get into it. What is the diamond? The
diamond complications of hemorrhagic shock is hypothermia, acidosis, coagulopathy, and hypocalcemia.
Hypocalcemia being one of the ones that you should keep track of. And when do you give calcium?
You're giving calcium for every 3 to 4 units of PRBCs. You're giving 1 gram of calcium gluconate.
Boom. There you go. So if you want to be in vogue, just follow that.
Hey, let's do another short. Let me ask you. What is the ratio of MTP and what is the order you are doing things?
Sure. So the ratio is 1 to 1 to 1. Packed red blood cells, FFP, and platelets. You're trying to mimic whole blood. It's going to help reduce coagulopathy. And a couple key extras. Give TXA if early in the trauma, less than 3 hours. And as we mentioned before, calcium for every 3 to 4 units of packed red blood cells. give 1 gram calcium gluconate, and then consider fibrinogen.
Yeah.
And that's it.
If you have whole blood, just use that alone.
Yeah.
Versus components.
Done.
Cool. Easy. Piece of cake.
So lastly, we'd like to mention one of our sponsors, EM News. And like we said before, you can find EM Rapid Bombs on Spotify. Go to Spotify, search for EM Rapid Bombs. You can sign up right through there. Or you can go to emboardbombs.com, search on our question bank, and find the podcast question bank there. Thanks, Briggs.
It's been a pleasure.
Always.
Hey, last thing.
Family.